I'd like to thank the organizers for the opportunity to speak on a topic that I'm particularly passionate about. And that passion is demonstrating the value of a product to ensure proper access for the patient population. This way, ensuring that the right patient gets the right medication for the right reason. My name is Alan Polnariev, and you may be surprised to know that more than half of all drug launches in the US fail to meet their expected revenue anticipation, and more than a quarter of those launches don't even reach half of what was projected. So now, more than ever, the stakes are higher to ensure a proper launch, to ensure pricing, reimbursement, and market access. Today, I'd like to share with you some information on extracting the value from real-world evidence and adding it to value-based healthcare. This is my disclaimer. The opinions that I share with you today are that of mine and mine alone, do not reflect my employer, past or present. And so I want to start off with a pair of historical case studies. The first, Glybera, which was approved by the EMA in 2012, never quite reached the US. This was a single curative therapy to fix a faulty gene in an ultra-rare condition affecting 1 in 1 million patients. The cost was at astounding $1.4 million US, and over the course of its tenure in Europe, 1 patient was treated. This was eventually pulled off the European market in 2016. So that is one side of the spectrum. And now the other side is with Repatha, which was approved in the US in 2017 to reduce LDL and the risk of cardiovascular events. Based on its trials, it showed a risk reduction of heart attack, stroke, and coronary revascularization. But once it passed the FDA's seal of approval, it wasn't met with the warmest of receptions by payers and those parties of alike. And the manufacturer had to go back, look through the data, come up with innovative refund contracts and more data and show its value. And now successfully has a healthy market share in the total PCSK9 market space. So another end of the spectrum. And so today we're going to discuss a few things, speaking to the market access landscape, some of the challenges and needs faced by our key stakeholders in healthcare, value-based healthcare as a whole, and in the context of market access, defining value, what it is not, who defines it and how, and put that in the context of value-based healthcare, and deriving value from real-world evidence. And so looking at a quick glimpse of today's US market trends, we are seeing health insurance shift from a defined benefit to that of a defined contribution. More and more, the onus is on the patients, higher copays, higher deductibles, and we're seeing this as a trend and does not look like it's going away anytime soon. There's the evolving provider landscape. The financial risks are merging in ways where the lines between payer and provider are starting to blur. And we can see this with the formation of vertically integrated ACOs such as Kaiser, Mayo, and Cleveland Clinic. There have been a number of significant landmark policies that have incentivized value over volume, quality over quantity. And value, of course, really does depend on the stakeholder's perspective. There's an increased interest in patient perspective, patient centricity, and this theme is definitely not going away anytime soon. And the use of social media for information communication. Patients are relying more and more on the internet and social media platforms to connect with other patients who may share a similar disease state and learn more about their disease. Increased scrutiny and demand for transparency in drug pricing. This is something that the pharmaceutical industry has been dealing with, and more demand on the industry for that kind of transparency. And there is a rising cost and focus on specialty medications. On the other hand, more stringent utilization management for these high-cost, high-yields medication to ensure that the value is substantial. The increased risk of value frameworks has been used to as a tool for utilization management to ensure that the value is substantial. And lastly, data-driven decision-making for the greater capacity and generation of real-world evidence and of application of this to help ascertain value. So now I'm going to share with you 5 of the key stakeholders in healthcare. This is not a comprehensive list, but some of the 5 essential core stakeholders in healthcare decision-making on a daily basis. And first and foremost, of course, are the patients. We've all been patients. We all understand what it's like. We want to feel better. We want to ensure that our out-of-pocket costs are managed, but we also want to improve our quality of life and minimize any kind of disease impact. Some of the challenges that patients face are higher out-of-pocket costs, like I mentioned, and new designs, new insurance schemes, plans to help make more options, but it also can add to more confusion for patients. And that leads me to my first of 6 tenets that I'm going to share with you today. These are nuggets of wisdom that I'd like to share with you, and I will recap them at the very end of this talk. And the first tenet is that each of the stakeholders that I'm going to mention, different stakeholders, have different and unique sets of wants, needs, concerns, and challenges. And it's up to us to understand our customers in any which way to understand and anticipate those challenges, wants, and needs. The next stakeholder are the providers and healthcare systems. They are in competition with each other and vying for more patients. So they want to ensure a better patient experience, better satisfaction scores from the patients, but also improve efficiency and coordination of care. Because as the rising cost of healthcare is a challenge for providers in healthcare, they want to ensure that they maximize quality measures and avoid any penalties and capitalize on any kind of bonuses that might be up for grabs. The pharmaceutical industry, many of us might be employees of the industry, and so we understand that the competition for patient access is fierce. There's a lot of companies vying for very limited spots, perhaps on a formulary, and so often these drugs have nuanced differences that really need to be highlighted. There's successful competition in the marketplace because this is the way that we're able to recoup profits for further investment in company endeavors. Some of the challenges, aside from the competition, payers are using more strict approaches from utilization management. Access to formulary is becoming more and more guarded. Longer are the days where the FDA can approve a drug, and that necessarily means that it's going to be paid for by insurance companies. There's also value frameworks, like I mentioned. I will go into that a little bit later, and the demand from payers for more real-world data. Policymakers. Well, policymakers have a utilitarian approach to things. They want to do the most right for the most good for the most people. They want to reduce overall spending, but improve societal health. Some of the challenges, well, increased pressure for funding high-cost therapies. I think we're going to see a wave of medications that are very high cost, but very high yield. And so paying for those, making that accessible is going to be a big challenge for the policymakers going forward. Payers, I think they have a very similar set of unique concerns, needs, and challenges like the policymakers. So what I'm going to do is focus on some of the considerations that a payer and policymaker might consider when a new product or healthcare technology comes out. Considering the patient's population exposure to a particular disease, how does this product or technology compare to the standard of care? How will this product improve the organization management to patients effectively? And how will this drug or product impact the bottom line? Can you show that you're going to be able to reduce hospitalizations or emergency room visits because of this product? Showing that is going to make or break a good or great value proposition. And so that brings me to my next tenet of the talk, is that being able to anticipate these wants and needs and challenges is critical for articulating a very crisp, concise value proposition. And often, these value propositions should reflect an improvement in outcomes while reducing overall costs. Value-based healthcare has been impacting all the stakeholders over the course of a number of years. Programs such as bundled payments, ACOs, quality payment programs like MIPS has really changed the landscape of healthcare, especially in the United States. Healthcare quality has become a major integral component of value. So I've used the word value a couple of times, and I want to define what it is, but I think it helps also defining what it is not. Value is not the same thing as cost or affordability. Cost and affordability is more of a short-term perspective that reflects a societal willingness to pay for some innovation and its specific impact on resource availability and allocation. On the other side, value, it takes in consideration a broader range of metrics, impacts such as economic, clinical, and humanistic outcomes, the ECHO model of outcomes. It's a longer-term perspective and includes quality over cost as a consideration for value. That brings me to my third tenet. Companies that fail to clearly articulate their value in their value proposition, for example, risk falling behind competition in terms of more competitive pharmaceutical companies that are doing the same thing but at a better rate or better job doing so, and more sophisticated payers that are scrutinizing these high-cost products to see if the value is incremental or substantial. So I talked about what value is, but who is defining it and how? Well, the cartoon on the right just reflects a payer or policymaker, for example, that is reflecting on some of the bigger questions that they might have in terms of a product's value. The organizations in the center are examples of those that have created what's called a value framework. We'll talk a little bit about that next. And overall, in the US, the healthcare system is certainly fragmented and decentralized. The term system I would use loosely. There are public payers, such as the federal government that pays for Medicare. There are state payers that pay for Medicaid. There's the private sector with national and regional organization, and it's just an alphabet soup of organizations that are involved in the whole US healthcare system. This is just an FYI slide showing examples of value frameworks by organizations listed on top that have created them. Organizations such as ASCO, NCCN, ICER have their own value frameworks, and they use certain value items listed on the left that reflect what is integral to that organization. So things like efficacy and toxicity are pretty much universal, and that's not going to go away. But organizations like ICER, for example, which is more of a pharmacoeconomic organization, may consider things like cost effectiveness and budget impact, where they may not consider things such as unmet need or novelty. So it really does depend on the organization's own concerns, wants, and needs and challenges. Again, each is unique in their own special way. And so let's start putting things together. How do these frameworks really lead to pricing, market access, reimbursement, value-based payments? So all of these frameworks share a very fundamental basis, a structure, a skeleton of how they work. So they select a particular outcome, maybe hospitalizations or ER visits, emergency room visits. They identify a relevant evidence base to aggregate those outcomes into a singular measure and help calculate and compare costs. So the image on the right shows the pathway in which good evidence generation can lead to successful value-based payments. And so a good pharmaceutical company early on in the development phase, maybe phase 2 or 3, would start to early on and create endpoints integral into these studies that reflect the value frameworks and maybe help influence or support value-based payments in their clinical trial design. This will get plugged into value frameworks, and this can help demonstrate the value of a product to increase reimbursement for customers in this value-based payment structuring. And so pharma's role in value-based healthcare is continuing to evolve. There are certain major themes. I chose 3 buckets that I think are going to continue to evolve going forward, including implementing bigger, better data to support clinical practice and value propositions. Evidence-based medicine has shifted from population-based medicine to individualized, that patient-centricity or patient-centric level. The improvement of measurement of clinical effectiveness, real-world evidence, and this is going to be helpful to supporting value propositions and also healthcare decision-making. And this leads us to not one, but 2 of my tenets in this talk. First, the pharmaceutical companies need to demonstrate the value of their products throughout the life cycle of the products with continuous evidence generation. And that goes hand in hand with tenet 5, which is developing innovative contracts and strategies for reimbursement, pricing, reimbursement, and market access. And together, pharmaceutical companies with their stakeholders need to work together, collaborate to identify particular types of endpoints, data, quality of life metrics, and so on that are integral to show that the product is of value. So I've used certain words already that I want to make sure that we're all on the same page on. On the left, I want to differentiate real-world data from randomized controlled trial. And I think this is a little bit more straightforward. A randomized controlled trial is interventional, it's a controlled environment, and it ascertains the efficacy of a product in a very limited population size. Real-world data, on the other hand, is real life. It's observational and has more of an unrestricted patient population. What's the difference between real-world data and real-world evidence? Well, this is more nuanced, and often the terms are used interchangeably, but there is a difference. Real-world data is the raw data that's collected outside of a randomized controlled trial. Real-world evidence, on the other hand, is the conclusions drawn from real-world data. This is what's going to be used to shape decision-making for the stakeholders that are evaluating the product. So let's start to put things together and see the flow of how this all works. Sources for real-world data include administrative claims, electronic medical records, clinical registries. This is going to lead to real-world data that's going to get funneled down to the conclusions drawn, i.e. real-world evidence. This is going to lead to upstream and downstream applications in the product's lifecycle. So upstream examples include proving clinical trial design, validating biomarkers, maybe even creating synthetic control arms for studies. Downstream effects include supporting regulatory submissions and label expansions, informing negotiations for formulary placement and drug pricing, and perhaps supporting performance agreements such as value-based contracts. But real-world data is not without its challenges. Over the past decade or so, I've seen an explosion in the number of real-world data abstracts and posters and studies. I think often they're good quality, but sometimes there can be poor quality analyses and a lack of uniformity in these trial designs and studies, limited transparency, and perhaps bias in results. So these are some of the challenges posed to real-world data. I think privacy concerns and convincing stakeholders of the value of these is another example of how this is being challenged. This slide is more of an FYI again to show that real-world data can and should be collected throughout the life cycle of a product, from the early days, preclinical days, all the way through phase 4. Now, payers' needs for data are evolving. From the traditional needs such as safety and efficacy, that will not go away, but payers are wanting more data, better data, and sooner. That includes how the product can offset medical costs. For example, one of my favorite examples to use is, can you show a reduction in inpatient visits or emergency room visits? Can you show quality of life improvement? Can you show cost effectiveness? Or absenteeism, presenteeism, depends on who the stakeholder is, but essentially the payer is looking for more kinds of data. As I begin to wrap things up, I want to share a pair of surveys that I particularly like. This first survey came in 2017 by Exenda. They asked 51 payers and 31 providers the types of data that they find extremely impactful in guiding decision making. What I took away from this, what I found most surprising, was that the similarities were more alike than I would have expected. For example, outcomes measurement was cited by 80% of both payers and providers. Similarly, efficiency of care was said by around 75% of both payers and providers. And so this told me that the similarities may be more alike and continue to evolve towards a similarity there. This next slide shows a survey from Deloitte in 2018, where they asked for the 3 most impactful areas for current, shown in green, and future, shown in blue, real-world evidence applications. So current applications include better understanding of subpopulations and heterogeneity, understanding burden of disease, and monitoring patient safety. And I think that's very apropos. However, future applications include optimizing the design of clinical trials, supporting regulatory submissions and label expansion, and design of value-based contracting schemes. So I can see how this leads us to my 6th tenet, that the applications of real-world evidence are evolving. And this ties into the purposes of this talk, in that pricing, reimbursement, market access is all going to be contingent on these high-cost, high-yield medications and how to support the value proposition. How do you put your money where your mouth is when you say that your product provides value? And so for my final thoughts, I just want to recap the 6 tenets that I shared with you. Different stakeholders each have their own unique set of concerns, wants, needs, and challenges. We need to listen actively to understand our customers and our stakeholders' concerns, needs, and challenges. If you can find a way to satisfy those needs, and typically it revolves around reducing costs and improving outcomes, you're on to successful strategy. However, companies that fail to clearly articulate their value risk formulary exclusion by both more sophisticated payers and more competitive companies and fall behind the competition. Throughout the product's lifecycle, companies can and must collaborate with their stakeholders to generate the real-world evidence based on the wants and needs of their customers. Innovative strategies to mitigate financial risk are paramount, and so strategies such as outcome-based contracts are becoming more and more prominent, and I think that will be the future. The applications of real-world evidence are expanding and evolving and include the development of such outcomes-based contracts. Again, my name is Alan Polnariev. Thank you very much for your attention.